joining us for our point of care ultrasound of the abdominal aorta. A lot of this is going to be review for you for physicians and practitioners, but hopefully you'll find some of the information helpful in your everyday scanning. So objectives for today are to identify the anatomy of the abdominal aorta and the prevalence of disease in this vessel. You'll also want to describe the protocol of abdominal aortic POCUS exams and discuss the most common findings on your POCUS aorta exam and the treatment steps required when you do come across these findings. So quickly, we're going to do a review of the anatomy of the abdominal aorta. As you know, it runs from T12 and bifurcates around L4 near the patient's umbilicus. The normal diameter of the aorta is going to be 2 centimeters or less. Anything greater than 3 centimeters is considered aneurysmal, unless it's throughout the entire aorta in possibly your elderly patients, which then could be because of ectatic changes of the aorta. When we look at the abdominal aorta in particular, usually you can start identifying it just below the diaphragm near the liver. The first branch that you're going to come across is the celiac trunk, also known as the celiac axis. Here you will see this right here on our diagram, and the importance of this celiac axis is that it is going to give rise to the branches of the hepatic artery, the splenic artery, and the left gastric artery. So when you're evaluating the abdominal aorta in transverse and you come across the iliac axis, the celiac axis, what we often see is what they call the seagull sign. So in transverse, you will see the wings of the seagull bifurcating into the hepatic and the splenic arteries. The left gastric artery is quite small and is often not visualized on ultrasound. The next branch of your aorta is going to be the superior mesenteric artery. So this is going to go on to feed the mesentery and the bowels, basically. And so at the superior mesenteric artery, this is going to come off the anterior aspect of the aorta, and then it's going to follow the aorta down relatively horizontal to it. Now, under the superior mesenteric artery, you often see the left renal vein coming across the anterior aorta to dump into the IVC. This they refer to as the nutcracker sign. So when you see a superior mesenteric artery and you see an anechoic region between the aorta and the superior mesenteric artery, that is going to be your left renal vein. The next branches are going to be your right and left renal arteries, and these are going to come off the lateral aspects of the aorta and go directly to the kidneys. Below that, we have the inferior mesenteric artery. This again is going to come off the anterior part of the aorta. This is again a small artery which may not be identified on your typical ultrasound. Below that, laterally, again, we find the gonadal arteries, which will be either testicular or ovarian arteries that are going to provide vascularization to the gonads. And then finally, at about L4, you're going to have that bifurcation into the left and right common iliac arteries. Some of the most common diseases of the aorta are going to be your aortic aneurysms. Anything that's over 3 centimeters, as mentioned before, is going to be considered aneurysmal. These aneurysmal arteries can be saccular in that they can be demonstrated as basically a sac off of this one side of the aorta, or they can be fusiform, where it's a general dilatation of a region of the aorta. So those are going to be your most common. There's also a pseudoaneurysm, where if there were to be some type of trauma to an aorta, that trauma would have been sealed off. And it will seal itself off, and however, you might identify a pocket of blood that can simulate an aneurysm. Some of the complications of an aneurysm include thrombosis. So because of hemodynamics of blood flow, if you have your arterial flow going through your aorta, it's coming into an aneurysm, and it becomes very turbulent in that region, it's not going to be effectively moving through that region as well. And we know that anytime that there is stasis of blood flow, like there would be possibly in an aneurysm, then you are more likely to develop a thrombus of that region. And we'll talk about how important it is to utilize your color flow and your grayscale adjustments to ensure that there is or is not thrombus in the region. Another complication of the aorta would be dissection. So dissection may occur with an aneurysm, but it may occur with a totally normal aorta. So if there is a dissection of the aorta, that tunica intima, that medial aspect of the aortic lining, would be sheared away from the wall. And when this happens, that blood flow moving through the aorta is going to be diverted into a true lumen as well as the false lumen. And that pressure into the false lumen can cause that aorta to continue to dissect farther and farther as it goes. Now, when you have that dissection, again, this is going to cause stasis of blood flow, and so these areas are more likely to have thrombus as well. And then finally, we can have an aortic rupture that could be due to trauma, changes in, it could be due to an aneurysm, or it could be due to some of the soft tissue changes in a patient. And rupture without immediate surgery has a 90% mortality rate. So this is something that you're probably not going to be finding in just your typical screening, but maybe are going to be coming across in a trauma situation. So the pathogenesis of disease of the abdominal aorta is going to be more common in people of advanced age, specifically males. It's got a 5.9% prevalence in males 80 to 85 years of age, and it's attributable for 9,000 deaths in the US each year. It's the 15th leading cause of death in especially males in the age of 60 to 64 age group, and it's going to be more common in those with other vascular diseases that are smokers or previous smokers, have hypertension, and those with connective tissue disease such as Marfan syndrome or other things like that. It's definitely a significant consideration, especially if you are taking care of a geriatric type population. So some of the symptoms of an abdominal aortic aneurysm would be abdominal discomfort or pressure. And then as a physician, clinically, you might be finding a palpable abdominal pulse. Now, this is something that we often see patients that are maybe young and thin directed to a sonography department for, because they find a palpable abdominal pulse. And oftentimes in the younger population, that is just simply due to the patient's small habitus and the superficial location of the aorta. But certainly if you're finding this in a more advanced age patient or somebody that has a much larger girth, then that would be of significant concern. And then finally, hypotension. If you're seeing a significant drop in blood pressure, obviously one of your concerns is internal bleeding, and so that would be a very alarming symptom of the disease. So screening for abdominal aneurysms is typically pretty easy. So the U.S. Preventative Services Task Force recommends screening of all men 65 to 75 with a history of smoking. That could also include people with high blood pressure or people with connective tissue diseases. Now, oftentimes these patients will be referred to a radiology department to have a full scan. However, it might be an option to do a point of care ultrasound screening just to take a quick look and identify if they need that full scan or not. We found that POCUS screening of the abdominal aorta has a strong correlation with CT measurements, and really they differentiate by only a couple millimeters typically. So it's a very obviously no radiation, cheaper, quicker exam to answer some of the same questions. POCUS typically has about a 97.5 to 100% sensitivity and 94 to 100% specificity. And obviously the sensitivity and specificity is increased by practitioners' experience and skill level at assessing the abdominal aorta. So when you're completing a POCUS abdominal aorta ultrasound, you're going to use your general abdomen transducer, usually about a 3 to 5 megahertz transducer. Obviously, if your patient is much larger in size, you may have to decrease that frequency down to maybe even 1.5 to 2. As you decrease that frequency, you are going to have a decrease in resolution, which is going to make those thrombus, dissections, things like that more difficult to identify, but it can still allow you to demonstrate the diameter of the lumen. You're going to want to evaluate the entire abdominal aorta in long and transverse. You'll want to begin at the patient's midline, right at the xiphoid region where the aorta is transitioning from the thoracic area into the abdominal area. You're not going to be able to see this well, obviously, in the thoracic area because of air in the lungs causing disruption of your beam, but as soon as it crosses that diaphragm, you should be able to pick it up relatively well. The aorta is going to lie just left to the IVC. If you're having difficulty determining if you're in the aorta or the IVC, you'll notice that the aorta is pulsatile. The aorta's pulsatility can actually reference to a pulsatility of the IVC as it bumps it. So just be aware that you want to be careful to ensure you truly are in the aorta. Some other differences you're going to see is that you're going to see respiratory changes of the IVC, which you would not find in the aorta. And then to be absolutely certain you're in the aorta, not the IVC, it never hurts to put your spectral Doppler in there and look for the type of flow. And with our aorta, we are going to see a very pulsatile, higher resistance flow, whereas with the IVC, you are going to have a respiratory variation of flow. And so by quickly evaluating that, you can identify if you are in the right vessel or not. You'll want to evaluate the whole length of that aorta, again, in long and transverse. If you start out in long, I recommend that you actually start at the most proximal area, follow it all the way down with a quick screening to the bifurcation, and you actually identify the bifurcation as this tapering area. If you just do a quick observation from top to bottom, it kind of allows your brain to, get a map what you have to evaluate ahead. So once you've done that, then you'd want to go back up to the proximal aorta, and then you're going to want to take anterior posterior measurements of the aorta at proximal, mid, and distal regions. Now, when you're measuring a vessel, especially the aorta, because it's an artery, it's going to have thicker vascular walls. And so you want to make sure that you're measuring just from the outside of the vascular wall to the outside of the other vascular wall. The other thing you want to make sure of is that you're not measuring at an angle like this. So one of the recommendations I make is to kind of make a visual length line, and then make sure that your measurement is perpendicular to that, because it can be tempting to measure at an inaccurate angle, especially when you're starting this, which would have a significant effect on the actual measurement. So just find your line and make sure that you're measuring perpendicular to that, including both vessel walls. So you'll want to measure that aorta in long, anterior-posterior projection, at the most proximal region, at the mid region, and at the distal region. And you should see as you do that the measurements are typically getting smaller as you go more distal in the aorta. The other thing you want to be aware of is that as you go from proximal to distal, typically, unless your patient has a large abdominal girth, typically you're going to see that aorta go from a deeper location to a more superficial location. And so as you do that, you should be identifying that you can actually make out those vascular lines or vessel wall lines a little bit better as you get towards the distal. Now, if you're ever not sure that you are at the bifurcation or not, you see this taper, but sometimes if you're off axis just a little bit, you'll actually elongate the common iliac. So if you're concerned you're on an iliac, you're not sure you're at the distal, just go ahead and go to transverse, and you'll be able to see the transverse aorta. And then as you scan down, you'll see it bifurcate into the two iliacs. And so then you just want to come up from those iliacs, turn on this in long, and that would give you the accurate taper of the distal end. Once you have all of that documented, then you just go ahead and you return to the xiphoid region, in transverse, and you're going to just do a quick evaluation down the aorta in transverse, looking for any surprises you may see there. Sometimes picking up a thrombus is a little bit easier when you're in transverse. So this just kind of allows you to, get all your thoughts together, see what's ahead, and then go back and do your imaging. So in transverse, you're going to want to look at proximal, mid, and distal again. Now in this case, as I'll show you in a moment, you're going to be measuring transverse or across the vessel for your diameter here. Now, anytime you're looking at the aorta, some of the things that you're evaluating for, like I said, is going to be that thrombus. So make sure that you do not have your gain turned down so low that it would cancel out any echoes from a thrombus. One of the best practices that I was instructed on is that once you have the aorta in sight or visualized well, you want to turn your gain up so that your image becomes as bright as possible, and then you slowly taper off that gain, making it darker and darker until you feel like you've gotten rid of all artifact, but not of any information. And that's one of the best practices in both our B mode or black and white mode scanning, as well as in our color scanning. So if we do find a thrombus, what you can expect to see is an echogenic material within the lumen that causes flow deviation. Now, the age of the thrombus is essential in identification. An early thrombus may be very difficult to identify because they'll have more of an anechoic appearance. So what you're really relying on there is looking for that color flow deviation. As a thrombus ages, it gets more and more echogenic, and if the patient's lucky enough to break down that thrombus, then it can become a little bit complex, where you'll see some mixture of echogenic and anechoic areas. If it's just a chronic thrombus that's going to stay, then you're going to see that as very echogenic. It would be easy to identify. So it's really those earlier thrombi that are a little bit harder to see. The other thing that you're looking for in the long and in transverse abdominal aorta evaluation is dissection. So dissection, as we talked about a moment ago, is going to be where that tunica intima gets pulled away from the aortic wall. So you would see that as a very thin echogenic line within the lumen. If you were to put color on this, you'd see color go to one side into the false lumen and color go to the other side into the true lumen. And that color or blood flow going into that false lumen is going to become very turbulent because it has nowhere to proceed to. So those are some of the things you're looking for dissection. Once you get to that distal aorta, we found the taper, you measured the taper, and then if you simply sweep your transducer to the patient's left and right, you should be able to assess those common iliac arteries opening up and long, and you'll want to assess those proximal arteries along with your aorta to ensure that they don't have aneurysms and that they don't have thrombus or dissection as well. Those should measure about 1 centimeter in diameter, and so you can use that numerical value to help differentiate normal from abnormal. So here's a couple of images of your aorta and long. So this is probably your most proximal region here that we see here that we're going to get the aorta and long. So here you see an AP measurement of the aorta would be anterior to posterior, including that vessel wall, and you'd want to take that measurement as high as possible. And as you can see, as I mentioned before, this is going to be the greatest depth of probably your entire scan. Now, within that proximal region, you are going to identify here the celiac axis, the superior mesenteric artery, the aorta, and then if you see an anechoic transverse circular region in here, that would be the left renal vein coursing from the left kidney towards the IVC. Okay. As you progress inferiorly, you'll see that the aorta comes a little bit more superficial. And again, here you're able to make out those intimal lines, or pardon me, those vessel wall lines a little bit better. So you'd want to measure transverse to the area there. And then you would follow it down to the taper as you saw on the last screen. Now, if you came across a patient that had thrombus, it might look something like this. This is not a brand new thrombus. This has been here for a bit of time because you have some echogenic area. Now, if I did not have color on this image and I measured from here to here, I would see truly there is an aneurysm. However, I could just identify that as an aneurysm and not realize that this patient has a big clot. So adding that color, making sure that your B mode or your black and white mode is set accurately is going to help you identify whether there's a thrombus in addition to that aneurysm. Now here's an example of what a dissection might look like. So it's just this line of tunica intima that's going to be within the vessel. You get a lot more information when you add on color flow here. Here you see the true lumen where you see blood flow is still moving the correct direction. And then here you see a false lumen where blood flow is getting a bit turbulent. This is essential that you have your 2D gain settings set correctly. Now, to be absolutely certain that a patient is not suffering from thrombus or dissection, the best practice would be to, after you're completing your scan in long, is to come back after you've taken your diameter measurements and then just do one more evaluation, putting color flow on that aorta, following it down from proximal all the way to the distal taper, looking for any changes of turbulence or deviation of flow or anything like that. All right. So then you'll go to your abdominal aorta and transverse, and here you're going to start again at the xiphoid area. You're going to do that observation from proximal all the way to the bifurcation. Then you're going to come back and you're going to start your measurements. So you measure again at proximal, mid, and distal. And then if you do happen to find an aortic dilatation, you are going to measure anywhere that that's noted, and we'll talk about that a little bit here in a moment. You're also making sure that your 2D and your color settings are set properly so that you can identify any dilatation, thrombus, or dissection. So here we see some transverse imaging of the aorta, and actually these are all pretty abnormal images. So what we see here in image A is that this aorta has a diameter of 8 centimeters, which would be highly beyond the cutoff of 3 centimeters that would indicate an aortic aneurysm. What you also see here is, knowing that there's an aneurysm, the tech or practitioner may have to adjust that B mode imaging to demonstrate that there is truly a thrombus surrounding that within that aneurysm. And so we would possibly, if we put color on this, it might actually look relatively normal in size because of the thrombus decreasing that lumen. But when you take the color off, you evaluate in B mode, you can really identify that there is an additional issue going on here. So in this case, you would just typically measure your transverse image just like usual, and then you would go back and you could measure the diameter of the true lumen that still continues, just to make record of that. Now in B, this is actually the same aorta in long at the same region. So here, because the sonographer or sonologist has their settings set appropriately, you can see that this low-level echoes would indicate that there is some thrombus within that lumen. Again, the measurement indicates that there is overall dilatation, and then that this is the open lumen. So that's a patient again with a AAA with thrombus. Here's another example over here where you see a very enlarged aorta, which you would measure straight across the vessel, and then it is highly highly affected by a thrombus there. You can see that there's different ages of thrombus within the overall entirety of the thrombus. So this echogenic area would indicate older thrombus, whereas this is probably some newer thrombus. And the complexity, or the anechoic region with the echogenic region, is kind of indicating there might be some breakdown of the thrombus in this region, but new thrombus is also building up. When we're looking at the transverse aorta, just following it down in transverse, and you see something like this, where you see some red, some blue, this would be indicative that there is either a big dilatation of the area where the normal blood flow is coming forward, but because the dilatation allows some turbulence, you get this backflow of blood as well. So this would indicate that there is typically a aneurysm in that area, or it could be indicative of a dissection. So this could indicate that this is the true lumen, and then blood is flowing into the false lumen, getting trapped there. So you'd want to follow up an image like this if you didn't see it in long, and you want to take your color flow off. You want to really play with your 2D gain and identify Is there a dissection, or is this just an aneurysm? So finding a AAA. So like we mentioned, really anything over 3 centimeters is typically identified as an abdominal aortic aneurysm. However, for patients that have a very ectatic aorta, it can be difficult to identify this because their whole aorta may measure over 3 centimeters in diameter. So in that type of case, what you'd want to do is identify an aneurysm where any area of the aorta measures greater than 50% more than the normal area. So if all of the aorta is measuring 3, but a particular area is measuring 4.5, then that would be indicative of an aneurysm at that 4.5 area, whereas the rest of the aorta may be just considered ectatic. Now, as I mentioned before, aneurysms can be fusiform or saccular or a pseudoaneurysm, so I won't bore you with the details on that, but you'll really be able to identify those best in transverse, and that's why it's so important to be going back, doing evaluations in long, evaluations in transverse, and evaluations in both long and transverse with measurement and with color flow. If you do come across an aneurysm, what you're going to want to do is measure in long. So if your aneurysm is looking something like this, you would measure proximal to at the widest region, distal to, and the length of the aneurysm, and document that information. The other essential information you want to identify is whether it is infrarenal, suprarenal, or involves the renals. And that's going to be essential in surgical planning. So you also, once your measurements are completed in long, you want to do the same thing in transverse where you measure proximal to a diameter at the widest region, diameter, distal to diameter. And then you're going to come back without any measurements and you're going to evaluate how the blood flow looks through those regions in both long and transverse. You're looking for turbulence, you're looking for thrombus, deviation of flow, all those types of things. If you do see a lot of turbulence, you can pop a spectral Doppler in there and just document a really significant disruption of our typical mid-resistance flow that we see in the abdominal aorta. The other important thing to do is identify if there's any free fluid around the aorta, which could mean that that's a leaking aneurysm or that a rupture is imminent or has already occurred. Okay, so general AAA recommendations, this is what we're seeing most of the field utilize, is 4 to 4.9 centimeter AAA. We'll call for a 12-month follow-up. If you get above 5 to 5.4, they'll reduce that follow-up to 6 months. And above 5.4, it can require elective repair depending on the patient condition. So if your patient is able to tolerate surgery, that might be an option for them. And obviously, if there's rupture, it's going to be imminent death if it's not repaired. So rupture would require immediate surgery. Okay, the AAA dissection, it's most common in the thoracic aorta, so these you won't necessarily find in the abdominal aorta if it began in the thoracic aorta, unless it has extended all the way out. And if you think about the blood flow, here's our aortic arch. Most of your dissections are going to come right off the aorta here. So you may not identify those because the air in the lungs would make that very difficult or impossible without a true echo being done. So, but however, if you get a dissection here and that pressure from that high pressure blood flow in that area causes it to kind of peel away, you may find it in the abdominal area. Well, this was a rather brief discussion on abdominal aorta and the common pathology here. If you have any questions, you can please let me know. We know that POCUS is a useful screening and bedside assessment tool for the abdominal aorta when used appropriately. It also can help plan patient treatment, whether it means to direct them for an official scan or to set them up for 6 to 12 month follow-up or get them to surgery immediately. It can be a very useful tool in that. It can also be very useful in bedside emergency situations where you're concerned about a rupture. Immediate results can offer rapid treatment planning, especially in cases such as those ruptures. Dissections and aneurysms are going to be the most common finding of the abdominal aorta and require immediate intervention. They can be assessed either in a radiology department or at the bedside. You can gather a lot of information to help that patient immediately. So thank you so much for joining us for this short lecture, and I hope you have a great day.